All right. 4 o'clock on the dot. Good afternoon, everyone. Welcome to another edition of Tumor Talk. I'm Randy D'Amico. This is a collaborative effort between Lenox Hill Neurosurgery and the Journal of Neuro-Oncology, where we like to highlight recently published articles in the journal. We talk really about the rationale for the study, the results, and hopefully the clinical relevance. Super happy today to have Caitlin Melnick with us. I believe you're chief resident, right? At University of Florida, the Department of Neurosurgery there. And she's going to introduce the topic she's talking about, recently published in the JNO. And I believe we're going to have her partner with her as well soon. So go ahead, introduce yourself. Tell us about what's going on.
Yeah, thank you so much for having me. My attending, Dr. Rahman, will be joining shortly. Hopefully she's just on call, so I think she's a little busy. But so we're going to be talking today about our paper that was just published. We're super excited about the results of it. So we were looking at basically the trial effect in patients with glioblastoma, which essentially shows that regardless of participation, which treatment arm the patient is enrolled in, there is a survival benefit of enrolling in a clinical trial for patients with glioblastoma. We have no disclosures, no conflict of interest. Can't use my keyboard to go forward. Okay, so we all know about GBM. Obviously, I think everyone here probably knows more about GBM than I do, but just an update on GBM right now. So there are currently 1,783 clinical trials on clinicaltrial.gov related to GBM. Of those, 493 are actively recruiting. Despite the large number of clinical trials, participation in clinical trials amongst patients with GBM is low. It's about 20% in one study. That's better than it is in all cancers, which clinical trial participation is only 3%, but still very low. Certain factors lead to poor enrollment in clinical trial, including certain race, low socioeconomic status, low education, patient perceived drawbacks, poor referral to the clinical trial, a number of things. And then this over here, again, we all know glioblastoma, but we just have one of our patients that we treated who kind of had a classic lesion with flare changes. And then within 18 months, despite maximal treatment, she had disease progression, crossing of the corpus callosum, and she ended up succumbing to her disease about 20 months post-diagnosis. So as I've already alluded to, the trial effect is an improved outcome for a particular disease based on enrollment in a clinical trial, regardless of treatment arm. It's been demonstrated multiple times in other oncologic diseases, but in GBM, it had previously been demonstrated twice. Both of these were studies out of Australia. The first one by Shahar et al. In 2012 had, I believe it was like 250 patients, and they were looking at patients from 1995 to 2008. They demonstrated that in the standard of care, median survival was about 12 months, and then in clinical trial enrolled patients, median survival was about 16 months, regardless of if they were in the control or the treatment arm. Then just a year later, a larger cohort of patients, this one was about 500, Field et al. In 2013, and they showed that clinical trial enrollment improved median survival to about 14.5 months compared to 6 months. We were interested in these studies, A, because they demonstrated such a profound trial effect, but B, because they were both done mostly before the Stoop protocol had been initiated. So a lot of these patients did not get what we now give as standard of care today. So we wanted to know that after the Stoop protocol, is there still a trial effect? And then also one of these studies in particular, Field et al., had a very low survival of patients who were not enrolled in clinical trials, well below what we consider the median now. So we just wanted to see if that number had changed at all. So again, we just wanted to demonstrate a persistence of a trial effect in the post-Stoop protocol era. So we included patients from 2011 to 2020. Essentially, our EMR started in 2011, so that was a good starting point for us. We identified patients based on ICD codes and CPT codes, which obviously is not very specific. So then we had to go through and manually exclude anybody with non-GBM histology. Worth noting, we define GBM based on the pre-2021 WHO definition. So these were patients that were, some of them had IDH mutant tumors because it was as GBM was defined prior to the 2021 rules. We also excluded duplicates, obviously, and we excluded children. Our statistical plan was to use inverse propensity score matching to prevent the trial enrolled patients from simply looking better because they were better patients to begin with, because presumably you have to be healthier to be enrolled in a clinical trial. So a priori, we identified 4 key factors that we thought were going to potentially change the outcome of the study. And those were all things that have been demonstrated previously in the literature, specifically age, baseline KPS, having undergone maximal safe tumor resection, and then treatment with temozolomide. We did a survival analysis with Kaplan-Meier curves, and the statistical analysis was a Wilcoxon rank sum because it is more sensitive to early differences as opposed to the log rank, which can look at longer term differences. This is just a table showing some of the clinical trials we have at our institution. The major ones of the patients included in our study were the To the Top and the ATTACK-2. These are big studies that we have. The PNOC is another big study, but since it's primarily looking at children and we excluded children, there was only a couple of young adults included in our cohort. And there was actually a good number of these other studies as well. It was pretty evenly distributed. So we found 1,160 patients based on the ICD and CPT codes. 640 of them did not have GBM. They had a metastatic tumor or anaplastic astrocytoma, something else. So that left us with 519 patients. 154 had to be excluded due to incomplete medical records, specifically since we were matching on baseline KPS and the extent of surgical resection. If that was not clearly indicated in the chart, then the patient was excluded. Some of our patients are referred to us after having undergone surgical resection, so the information just was not always there. That left us with 365 patients in our final analysis. Of that, 89 were enrolled in a clinical trial and 276 were not. That comes out to like roughly 30% of patients enrolling in a clinical trial, which is higher than the literature. And I think we can owe to a great system of nurses and clinical trial staff that are just great about getting our patients enrolled. Looking at our results here, comparing the clinical trial group and the standard of care group, there were some significant differences. So the baseline KPS was worse in the standard of care group. That's okay, because we end up correcting for that with the propensity score matching, as was the surgical maximal safe resection and having undergone treatment with temozolomide. There were other things that trended towards being different between the two groups, specifically getting radiation, and then presentation with multifocal or widespread disease, and then age as well trended towards being different between the two groups. So looking at the result of our propensity model, these were the 4 factors that we identified a priori, as I said, and their associated odds ratios. Pre-propensity score matching, we have the differences between the two groups here. This was what was shown in the previous table. And then after the propensity score matching, we can see that the groups are much more similarly matched. And kind of the meat of our paper here is our results. So essentially we showed kind of what we expected, which was that clinical trial participation did improve median overall survival. So we can see clinical trial here in the red and no clinical trial in the black. And throughout the whole early course of the disease, participating in a clinical trial seems to show survival benefit. As we can see at the end of the disease course, the number of what many papers would call very long-term survivors is not significantly altered by trial participation. We all know that there's something special about those patients that results in their, very long survival, and presumably participating in a clinical trial is not affected by that. This is our table here just showing our median overall survival. I presented it in years, but our overall cohort lived longer than what would be expected just based on the literature today. So even patients who were not participating in a clinical trial exceeded the median survival that we all kind of say of 14 months. We say 14 to 20. So we were on that higher side of that. Whereas patients who did participate in a clinical trial were living almost 2.5 years. So there's a clear benefit to participation there. And then the log rank and Wilcoxon were both statistically significant. An interesting thing that we consider that was probably a likely confounder of this study was that patients who participate in clinical trials are following with neuro-oncology much more frequently. And that result was statistically significant in our paper as well. And we think that there might be some sort of benefit to just regularly being seen by a neuro-oncologist and having kind of closer disease monitoring, and perhaps that could be leading to this improved survival. So our conclusions, like I already alluded to, we think that patients who have GBM who participate in a clinical trial are much more likely to have an improved median survival, regardless of what treatment arm they are in. But we think that that result might be biased by just an increased frequency of neuro-oncologic care.
Yeah,
Thanks so much. Yeah, great.
I was going to say, I want to thank you for presenting. Obviously, I think you and your colleagues have done a marvelous job. It does sort of raise a number of questions. And as I was listening to your presentation, having already read your report, I wonder, oftentimes where we see early phase trials in glioblastoma comparing to historical controls and noticing a difference, and especially when those historical controls may have been from an earlier era or an era where the frequency of follow-up may not be what it is in the current era. I mean, I think your study suggests that there may be some challenges with using that data, the historical control data. So I wonder if you might, either or both of you might give your thoughts on study design and the implications of what you found. I mean, should we be looking at these early phase 2 or phase 1, 2 studies and comparing to historical controls, or should we really be waiting till we get to a pivotal phase 3 trial?
Caitlin,
I know that's not there's no right or wrong answer here, but I think it's a provocative study, and it made me sort of think more about, because we publish these sorts of studies with some frequency in neurosurgical neuro-oncology and other neuro-oncology journals and neurosurgical journals. But go ahead.
well, thank you for the invitation, Jason and Randy. Appreciate you guys allowing us to come share our work. I completely agree with you. I think, using historical data to compare our current clinical early phase trials it basically has no value. And especially now that we've changed our WHO criteria for gliomas, like we're significantly biased. We're now including a certain cohort of patients as glioblastoma or grade 4 gliomas that weren't previously categorized in that fashion. And so I think it's a large mistake. I think that for phase 1 and 2 studies, really our readouts should be biomarker and tissue-based readouts, and we should learn something about the mechanism of action and the physiology of the therapeutic using tissue and window of opportunity trials. But trying to glean something by comparing the clinical outcomes with historical controls is just a mistake.
Yeah, I mean, it's a difficult thing we have to struggle through, but I think you're right that, those comparisons that you just alluded to also all cost more money, right, than launching something off the ground. So we get into the usual argument of, well, we have to improve funding for these things, whether it's philanthropy or more grants or government sponsored studies and whatnot, or industry sponsored studies. But I completely agree. I think the most remarkable thing, there's two things that really stand out to me. Number one, 30% is a high number of patients getting into clinical trials. That's, abysmal, really. I mean, 30% is nothing. And it's still the best we can do and better than most people. And you guys are at a fantastic institution that's really out there getting patients in. And so, I tell patients now, with a glioblastoma, you're not allowed not to be in a clinical trial. And I really don't care if you're going to go to a different institution to find one, but you need to be in one. And I think your paper highlights the reason why, which is that now, previously and now with your paper after Stu protocol, doing the best that we can do with patients that are matched, you're still going to do better by enrolling in a clinical trial, even if the drug doesn't work, whether it's just frequent follow-up or, a Hawthorne effect type of scenario or something. And so, that's what stands out to me the most, I think from listening to, I don't know if you guys have comments on that or not, but it's kind of me getting on a soapbox.
I agree, Randy, and I'm sorry, Jason, to interrupt. I would say that one of the problems that we have is that we do not have clinical trials for a large number of patients, the elderly with bihemispheric disease, or gliomatosis type pattern radiographically. And so then ideally we want to enroll them in a trial, but because of their age or their disease pattern, they're not candidates, or prior therapies, they're excluded. And so there is a little bit of a balance between designing the perfect trial and then having trials available for these patient cohorts. Funding is a big part of that. But yes, I agree.
Yeah, I was going to say, I was very impressed. I mean, 30% accrual to clinical trials is vastly better than most centers. And I wish we could get individuals on trials. Many patients I found who are very eager to get on a trial are not very eager to get on them if they're not in the intervention arm. And so if they get accrued to a trial and they find out that they're, and some of the trials obviously are blinded to know whether or not they're getting the intervention or not. Obviously, drug trials are a little bit easier to do than procedural-based trials. But if they find out that they're randomized to the control arm or the standard of care arm, they'll move on to another institution and withdraw from the study and move forward to a trial that they think might provide them with an intervention that would be above and beyond standard of care. So it does get tricky, and I think to the point raised earlier, Randy, you're right. I mean, having an adequate control arm is not easy and it's expensive, and it adds time to the efforts of investigators, clinical research coordinators, and frankly is a challenge for caregivers and the patients themselves who say, look, if this is all I'm doing, I don't necessarily need to come back these extra times for these extra tests, blood biomarkers and other sorts of things that are not necessarily standard of care, even though they may be receiving standard of care treatments. So,
yeah, definitely. Listen, one other question. Did you notice anything about reoperation rates, maybe in patients who are involved in trials? Basically what I'm alluding to is, why does a more frequent number of visits with a neuro-oncologist lead to better outcomes? Because a neuro-oncologist is looking at the same MRIs we all look at, right? So what is it that you guys think changes that dynamic?
Yeah, that's a really great point. We've used this patient cohort to look at something similar, but we've never looked at it that way to see if the trial enrolled patients are having more operations. That would certainly make sense. But I think even in the absence of more operations, just potentially changes in therapy due to changes seen on imaging that otherwise might be missed or delayed in being identified because the patients aren't being seen at these regular intervals. I don't know.
Yeah, I think to add to that, when they're seen by neuro-oncologists, there's usually modified RANO criteria being utilized to evaluate the scans and for decision-making, and the threshold for sending them to us, because they work closely with us, sending them to us for early biopsy or consideration biopsy or lit or surgery to come up with a diagnosis is probably sooner. And oftentimes our patients who are getting treated in the community, which is, the community docs present a huge value for these patients because they don't have to travel. But oftentimes the criteria for evaluating the MRI is not necessarily modified RANO, and their threshold for a worsening scan and kind of deferring surgery or intervention and continuing to follow or treating with steroids instead to kind of while you're watching things, I think that time period is longer compared to when they're under the care of a trained neuro-oncologist. That's just my personal impression. And we don't have data to support that, but that's my general impression.
Yeah, absolutely. I think it makes a ton of sense. And, again, I think that this is something that I'm curious if Caitlin, you're going on into practice now. Are you going to use this to counsel your patients, right? Are you going to say, look, we knew it in the past. We know it again. You need to be on a trial.
Yeah, I mean, I think we should tell every patient, every GBM patient, like you said, that you have to be on a trial. If there's one that you're eligible for, get on it because it's clearly beneficial. And I think that's, in a disease that carries such a terrible prognosis, providing something that clearly gives a glimmer of hope is important. And I think that, like you said, every patient with GBM should be seeking out trials.
Yeah, one of the things I think about a lot is trial design, and being careful to not limit people's options down the road also, which is tough, right? It gets into the, again, these kind of early stage trials where, for instance, I know a trial, where you have to have STU protocol to get into the trial, basically. But STU protocol eliminates some other things that you could potentially do, such as like cesium brachytherapy, or a whole variety of different things. But I'm sure you guys know what I mean. But it becomes difficult with trial design to not limit a patient's options for their recurrence, right? Which is still happening, as we know, and down the road from that too. And so, again, I think it's a complex system, but you have to be on a trial.
One of the things I was going to ask the two of you, you've done a marvelous job of patient accrual. Have you seen or have you integrated since COVID more telemedicine points of contact in your clinical trial designs and your clinical trial follow-up of patients? What's the success? What do you attribute your success in terms of the 30%, which I think is incredible for accrual? And what tricks of the trade do you attribute, besides the marvelous personnel and the great clinical trial designs that you have? How are you doing it?
So a couple things. Yeah, telemedicine is definitely incorporated, although, in clinical trials, a little bit limited because they still need to come and have certain labs drawn
Right.
and certain MRI scans done for some of the secondary endpoint biomarker type things that we're looking for. But the way that we get high enrollment is that we have taken it out of the hands of the physicians. If you are requiring a doctor to remember that I'm seeing this patient may be a candidate for this clinical trial, like that may happen, it may not happen. It depends on the physician and how often they're engaged in the clinical trial, whether or not going to refer. And so essentially every single one of our patients with a brain tumor is consented for the Florida Center for Brain Tumor Research, which is a statewide biobank that's housed at the University of Florida and kind of administered at the University of Florida. They get consented to collect tissue. So every single brain tumor patient is now going through our research, essentially research personnel. And so they will automatically get screened for any potential clinical trials that we have. And so no one has to remember and think like, oh, this person has this, or a newly diagnosed GBM. They may be able to enroll in our new RNA nanoparticle vaccine, and we have to collect tissue at the time of surgery. They are already like in clinic, when they come through the ER, someone's already screening them, getting consent for tissue, and at the same time screening them for all clinical trials. And so we don't miss potential patients in that fashion. In addition, in our tumor board, for everyone who has mostly brain tumor, because we don't have any clinical trials right now for spinal tumors, but brain tumor, they get kind of screened through, like at the end of the discussion is like, okay, did every single one of these patients that we just discussed, are they potential candidates for a clinical trial and that we missed them somehow? So that's kind of like the safety net, but it's to take it out of the hands of the doctors and put it in the hands of people who are thinking this all the time.
Well, I mean that certainly is I think important information to share for all those who are watching this webinar, and I think it's things that can be amplified at other sites. I mean, those are things we do a little bit of at my institution, probably could do much more of based upon what you've just said, and your results again we'd love to have everyone on the trial, but that's not going to always be feasible, as you've indicated. But I think you've done a marvelous job here of underscoring your successes for how you've been able to accomplish 30% roughly accrual. And then, clearly, I think the study that you've just done is a marvelous, thought-provoking one. And I'm so glad you're able to share it with us today.
I agree. Thank you guys so much. We like to keep it short and sweet here. I want to thank you all, not just for, choosing the Journal of Neuro-Oncology to publish in, but also for publishing a paper that I can use to help get more accrual in clinical trials. And so thank you guys very much. Have a great afternoon, and we'll see everyone next week.
Thank you, guys. Great seeing
Thank you.
All right. Take care.
Bye-bye.
Bye-bye.